Welcome to the second session of teleconference. In our previous session, we introduced the 2 months to 5 year older child, and we discussed 3 symptoms. That is, we discussed general danger sign, then we discussed respiratory problem and diarrhea. Now we will be discussing about fever. So I will request Dr. Chalani to initiate the discussion on fever component.
Thank you, Dr. Jana. Viewers, now we are moving on to the third main important symptoms, that is, does the child have fever? Now in this box we will enter only when there is a history of either fever from the parents, or when we feel and the child appears hot, or when we record the temperature when the temperature is more than 37.5 degrees centigrade or above. Now if by these 3 ways, if we say that the child has got fever, then we will enter this box and then we'll assess the child for fever. Now in the we'll just see that in the assessment box, first question is to find out whether the malaria risk is high or low. Because each area is known, and most of the places the malaria eradication officers, they have the mapping of these areas and they tell us whether this area belongs to high or low endemicity. Now if the malaria risk is high, and in the places where P. falciparum incidence is very high, we do the rapid diagnostic test and find out whether the test is negative or positive. Then in this we ask further question for how long the fever is persisting. If the fever is persisting for more than 7 days, that means the child has got some other causes which requires assessment in the form of the lab investigations in the hospital, and the cause may be either the enteric fever or tuberculosis or urinary tract infection. The next question we ask, has the child had measles within the last now or within the last 3 months? Now this, because if the child has got measles now or within last 3 months, we will assess the child for the complications of the measles. So having asked these questions, we will proceed for the further assessment of this child by looking and feeling. Now can we have the video to show us how to assess a child with history of fever?
History of fever during this illness, or who feels hot, or who has a temperature of 37.5 or higher. Ask,
does the child have fever?
It is important to make sure that the mother understands what fever is. Use a local term for fever, or ask the mother whether the child's body has felt hot to her. A child may not be suffering from fever at the time when it is brought before you. However, it is important to know if the child has had fever with this illness.
Fever is assessed because fever in a sick child can be a sign of serious illness, such as malaria or measles. If you do not have a thermometer, feel for fever. Feel the child's stomach or under the child's arm and determine if it feels hot.
Assessing a child for signs related to fever is a 2-step process. The child is first assessed for signs of malaria and for measles, and then, if measles is present, for signs indicating complications of measles. First decide the malaria risk. Is there a high or low risk of malaria? Then ask,
for how long?
If the fever has been present for more than 7 days, ask,
has fever been present every day?
Ask,
has the child had measles in the last 3 months?
next, look or feel for stiff neck.
It's important to assess a child with fever for stiff neck because the child may have meningitis.
First, watch to see if the child bends his neck while looking around. If he does this spontaneously, he does not have a stiff neck. If he does not bend his neck when looking around, encourage the child to bend his neck by drawing his attention to his toes. This is generally more effective than trying to bend the neck with your hand, since many children will automatically respond by tightening their neck muscles.
If the child can look down, almost touching his chin to his chest, there is no stiff neck. If you are not successful in getting the child to bend its neck, you should slowly, gently, put your hand behind the child's head and try to bend the neck. The neck should move easily.
Look and feel for bulging fontanelle. This sign can be assessed only in children who have an open fontanelle. The fontanelle closes in most children by 18 months of age.
Next, look for a runny nose.
A runny nose in a child with a fever may indicate a cold. In a low malaria risk setting, observing whether a child has a runny nose helps to distinguish whether the fever is due to malaria or a cold.
Look to see if there are signs suggesting measles. Look for a generalized rash.
In measles, a red rash begins behind the ears and on the neck. It then becomes generalized. That is, the rash spreads to the face and body. Then the arms and legs. A generalized rash like measles covers the whole body. It should not be confused with a rash like scabies, which is usually found on the arms and stomach. Nor does measles appear just as a rash only on the face or on the scalp.
A child with measles will also have one or more of these 3 signs: a cough, a runny nose, or red eyes. If the child has measles, move on to the second part of the fever assessment. When a child has the signs of measles, it is important to continue assessing the child for signs of eye or mouth complications. Look for mouth ulcers. Are they deep and extensive? Look inside the mouth for mouth ulcers. This child doesn't have mouth ulcers.
But this child does. These are painful open sores on the inside of the mouth, lips and tongue. They may be red or have a white coating on them. Mouth ulcers make it difficult for the child to drink or eat.
Next, look for pus draining from the eye.
This child has pus. Measles can be complicated by an infection of the conjunctiva or white part of the eye. This can be identified by the pus which collects in the eye.
Look for pus on the conjunctiva, or eyelids, or draining from the eye. Next, look carefully for clouding of the cornea.
The normal cornea is bright and transparent. Through it, the iris and the round pupil at its middle can be seen. A normal cornea allows you to see the color of the iris clearly. The pupil is black. Measles can cause a white spot or clouding to appear in this part of the eye. The clouding may occur in only one or both eyes. When exposed to light, the condition may cause irritation and pain, and the child keeps the eyes tightly shut. Corneal clouding can progress to bad ulceration of the cornea, like this, which can result in blindness.
That completes the assessment process for fever.
So friends, we have assessed the child and we have seen the video of the assessment of a child with fever, and we have seen how to assess for the stiff neck. Then we have seen how to assess the child for bulging fontanelle, because if there is a presence of a stiff neck and bulging fontanelle, these are again points which signifies the severe illness. We also look the signs of measles and also the complications of measles. Now let us go and see how to classify a child who is having fever, and for this we classify either into malaria or in the box of the measles. Let's see the first row. Dr. Jena, can we have the first classification? For malaria we classify into high risk and low risk. And any child who is having presence of general danger sign, stiff neck and bulging fontanelle, it places the child into very severe febrile disease. Now next box is divided into two categories on the basis of on the basis of the presence of RDT, that is rapid diagnostic test, either positive or negative. We can focus on this that fever by history, if it feels can we now we can appreciate in this box that if the child is in the yellow box, if we see fever by history or feels hot, or when the temperature is more than 37.5 degree and RDT test is positive, it is malaria. And however, if there is RDT test is negative, then it is clinical malaria. About the treatment modalities we will learn a little later. So high risk category of fever in the malaria box is divided into very severe febrile disease, malaria and clinical malaria. This is a change from the previous guidelines of the malaria, where we had only two boxes, that is fever, very severe febrile disease and malaria. Here in addition now we are having clinical malaria also. We move on to the next. If the malaria risk is low, then there are three boxes we can appreciate. As we know, in low risk malaria we are not doing the rapid diagnostic test at present according to the recent guidelines of the malaria. If there is any general danger sign, stiff neck or bulging fontanelle, it places the child into very severe febrile disease. Or when there is no runny nose, no measles and no other cause of fever. Now please remember, when we classify the fever, we are here classifying for malaria and measles. The other causes like cough, pneumonia, diarrhea, they have already been covered in the previous section which we had discussed. Similarly, the ear problem, which will follow later. So if there are no runny nose, no measles and no other cause, it places the child into clinical malaria. And if there is presence of running nose or there is some other cause of fever like diarrhea, upper respiratory infection, or some boils or furuncle, then it places the child into fever, malaria, unlikely. So this is how we classify the box of the fever for malaria. And now if there is a history of measles now or within the last 3 months, we have seen the video of how to see the complications of the measles. We had looked for the mouth ulcers. We had also seen the red eyes where the pus was draining out, and we had seen the clouding of cornea. On the basis of this, we classify measles into again 3. If there is presence of general danger sign, clouding of cornea, deep or extensive mouth ulcers, it places the child into severe complicated measles. However, if there are no signs from the red box and there is just pus draining from the eye or mouth, then, or there are presence of mouth ulcers, it places the child into measles with eye or mouth complications. And if there are no complications, there is just the rash which was present, then it classifies the child into measles. So this is how we classify the box of the fever. It's a bit complicated as compared to other boxes. What we have to remember is the identification first of the malaria risk, whether it is high risk or low risk, and then on the basis of the rapid diagnostic test in the high malaria risk, we categorize them into various zones as we had discussed. And it is also important for the measles cases because the complications, they are there in the next 3 months, because these children, they become immunocompromised after measles illness. So complications, they can be seen in the 3 months, and that's how we classify that illness. Next to Dr. Jaina for the next main symptom.
So I want to highlight here what Dr. Chalani has already told. If you see the slide, can you show the slide again? So you will see the classification of, please show the slide here. Can you show the slide? Yes. So if you see where high risk zone, then malaria will be either it is very severe febrile disease, so if you see either it is very severe febrile disease, or there are 2 more yellow box. Previously we had only 1 box, but now since this year there has been a modification. So in the classification there are only 2 classifications. One is malaria and one is clinical malaria. If it is RDK positive, then it is malaria. If it is RDK negative, then it is clinical malaria. Similarly, for low risk zone, there are 2 boxes. One is clinical malaria and another is so another is fever, malaria, unlikely. These classifications are almost similar as we had shown in the chart, but the word malaria will be replaced by clinical malaria. So if you see, the word clinical malaria is being used in contrast to the word malaria previously which was used. So now we will go to the next component, that is ear infection and then malnutrition and anemia. So now I will request Dr. Prasad to highlight the next main symptom, that is ear infection. Dr. Prasad, please.
Thank you, Dr. Jaina. Well, these 3 problems, ear problem, malnutrition and anemia, have been clubbed together, but in chart booklet you will find them 3 different boxes. The first box, ear problem, remember that every child does not require assessment of ear problem. then question comes, which child needs? For that you have to ask mother, does the child have any ear problem? If mother says yes, then that child requires assessment of ear problem. So, if mother says child has got ear problem, on the case recording form, there are two things, yes or no. So, you have to tick mark yes and then go on assessing the ear problem. Assessment is very simple. You have to ask, look and feel. You have to ask 2 or 3 questions. What questions? First question, is there any ear pain? Second question, is there ear discharge? And if yes, for how long? Look, you have to look for pus draining from the ear, and you have to look and also feel for tender swelling behind the ear. This is how you assess, and then you can classify this ear problem. Classification is very simple. We always start classifying from the pink row, that is, we try to find out the severest form first. So if a tender swelling behind the ear is present, the classification is mastoiditis, which is a serious problem. If tender swelling behind the ear is not present, then we come down to the yellow row and try to see that if we found pus draining from the ear and the discharge has been reported for less than 14 days, or there is ear pain, in that condition, the classification is acute ear infection. Suppose you have seen the pus draining from, suppose this is not present, then come down and you find that you have seen pus draining from the ear, but the discharge is reported for 14 days or more, then the classification is chronic ear infection. And if none of these things are present, you again come down, there is no ear pain and no pus seen draining from the ear, then the classification is no ear infection. So that is about the ear problem, which has to be done only when the mother says that child has got an ear problem. Next is this malnutrition, and you know malnutrition is a compulsory box. You have to do assessment of all the child age 2 months up to 5 years for malnutrition. You have to check the child for malnutrition. And again, you have to look and feel. Very simple things you have to do. First, you have to look for the visible severe wasting. You have to look for the edema both feet. And you know that at the beginning you have recorded the weight of the child. Now you have to plot that weight on the graph. And you must be remembering that in young infant you have already learned how to plot the weight for age on the graph. So depending on these findings, you can classify the malnutrition. Suppose if we again start from the pink row, and if we found that visible severe wasting or edema both feet are present, then the classification is severe malnutrition. Suppose the child does not fit in the pink row, we come down to the yellow row, and if you have plotted the weight and you found that child has got malnutrition grade 2, 3 or 4, then the classification is very low weight. Suppose child does not have any of these things, you again come down to the green row and you can classify not very low weight. Coming down to the anemia, again very simple. Just you have to look at the palm of the baby, compare with some healthy person's palm, and then see if palmar pallor is present. And if pallor is present, it is severe palmar pallor or some palmar pallor. That you will see in video also. But classification is that very simple. If severe palmar pallor is present, in the pink row we classify as severe anemia. If some palmar pallor is present in the yellow row, we classify as anemia. And if no palmar pallor is present, then we classify as no anemia. So whatever I have said about all these things, you can see in the video also, and then you will appreciate better than what I have said. Can we all see the video?
We will see how to assess for an ear problem and then check for malnutrition and anemia. Ear infections rarely cause death, but they are the main cause of deafness in developing countries. An infection can spread from the ear to the brain, causing meningitis. To assess for an ear problem, first ask the main symptom question.
Does the child have an ear problem?
If the mother replies that there is an ear problem, assess the child further. Ask.
Is there ear pain?
Ask.
Is there ear discharge?
If the mother says yes, ask.
For how long? Ear discharge is a sign of infection. The duration of the ear discharge is important when deciding whether to treat the child for acute or chronic ear infection.
Next, look for pus draining from the ear. Look closely into each of the child's ears. Next, feel for tender swelling behind the ear. You should feel behind both ears like this to determine if there is tender swelling of the mastoid bone. The mastoid bone is the large bone behind the ear.
Tender swelling behind the ear may indicate a deep infection of the mastoid bone. Both tenderness and swelling must be present to classify mastoiditis.
That completes the assessment for an ear problem. The health worker would classify the ear problem.
Check for malnutrition.
It is very important to check all sick children for signs suggesting malnutrition and anemia. Look for visible severe wasting.
To look for visible severe wasting, remove the child's clothes. Look for severe wasting of the muscles of the shoulders, arms, buttocks and legs. The hips look small compared to the chest and abdomen. Look at the child from the side to see if the fat of the buttocks is missing. A child with visible severe wasting may still have a normal appearing face and a large or distended abdomen. This child has visible severe wasting. A child with visible severe wasting has marasmus, a form of severe malnutrition.
Next, look for edema of both feet.
To determine if a child has edema of both feet, the health worker uses her thumb to press gently for a few seconds on the upper side of each foot. If a dent results in both feet, the child has edema. This child does not have edema. Edema is an important sign of kwashiorkor, a form of severe malnutrition. This child has kwashiorkor. This child has edema. The edema or swelling is due to an accumulation of fluids in the child's tissues.
If the child has not already been weighed and his weight recorded during this visit to the clinic, the health worker weighs the child.
A child's weight for age is another indicator of malnutrition. A child with a very low weight is malnourished. He needs to have his feeding assessed. Determine the child's weight for age using a growth chart.
Check for anemia.
Look for Palmar pallor.
Pallor is an unusual paleness of the skin and is a sign of anemia. Children with severe Palmar pallor have severe anemia. To see if a child has Palmar pallor, look at the skin of the child's palm. Hold the palm open by grasping it gently from the side. Do not stretch the fingers backwards. This may actually cause pallor by blocking the blood supply. Compare the color of the child's palm with your own palm, or with the palms of other children. This child has severe Palmar pallor. The palm is so pale that it looks white. This child has severe anemia. If the skin of the child's palm is pale but not white, the child has some Palmar pallor. This child's palm is normal. It is a healthy pink color. This child has severe pallor. Anemia occurs in children who are not eating foods rich in iron, or who have malaria, hookworm, or whipworm. Severe anemia can be life-threatening.
Next, the health worker checks the child's immunization status. Assess the child's immunization status. Decide whether any immunizations are needed today and when the child should come back to the clinic for their next immunization. If the child is well enough to go home, the child should go home with his immunizations up to date. Finally, assess any other problems the child has. This completes the assessment of the sick child, aged 2 months up to 5 years.
So, by this time, you have checked for the general danger sign. You have assessed and classified for the main symptoms of cough or difficult breathing, diarrhea, fever and ear problem, and you have checked for malnutrition and anemia. You have seen in the video that the next is check for the child's immunization status and give immunization which is required today. Another thing is that what you have not seen in the video is that also check the status of the prophylactic vitamin A which is required by the child. So check that thing. If child requires vitamin A, you have to give vitamin A and plan future vitamin A also. And you also have to check for the prophylactic iron and folic acid supplementation status, if the child has received or not. That you have to check. And finally, if there is any other problem which could not be covered by the above boxes, that you have to assess. So that completes the assessment and classification of a sick child aged 2 months up to 5 years. Once you have classified, the next step is to identify the treatment, and I think for identifying treatment, I hand over to Professor Anju Seth, who will talk to you about identified treatment.
Thank you, Dr. Prasad. As Dr. Prasad has said, we have completed the assessment and classification of a child 2 months up to 5 years of age. The next process, the next step in the management process of this child is identify the treatment. For every classification that the child has got, there is a planned treatment, and this is mentioned in the last column of the classification table. we can just focus there. The top line here says identify treatment. Now when we want to identify the treatment, the first thing that we want to do is determine if the child requires an urgent referral. And how do we do that? We do that by finding the pink classifications. Now let's have a look at the case management chart and see for what all classifications a child has a pink classification and requires a urgent referral. These include severe pneumonia or very severe disease, severe dehydration, severe persistent diarrhea, very severe febrile disease, severe complicated measles, mastocytitis, severe malnutrition, severe anemia. Now, in addition, if a child has got a general danger sign and has not got any other pink classification, he would also require referral. Now that's a very rare situation, because in most of the situations if a child has a general danger sign, he will get captured somewhere along these pink classifications. However, in a situation where that does not happen, then even a child with any general danger sign without any other pink classification should also be referred urgently. Another situation where a child might require urgent referral is if a child has got another severe problem which this case management process is not including. Say, for example, the child has a severe abdominal pain. You would have noted that this chart does not cover that. What we have tried to do in this chart is that what's included are the most of the common reasons. We might leave out a few. So if a child has a severe abdominal pain, that child would also require to be referred. Now once we have identified children who require urgent referral, the steps of management include identification and administration of urgent pre-referral treatment. Now this urgent pre-referral treatment is there in the identified treatment column in bold letters. So one can quickly look at the bold letters and we would know that this is the pre-referral treatment required. For example, for a classification of severe pneumonia and very severe disease, the child requires first dose of injectable chloramphenicol. If not possible, give oral amoxicillin. Refer urgently to hospital. Likewise, we can see it for other classifications. For example, a child with severe complicated measles requires first dose of vitamin A, first dose of injectable chloramphenicol. If not possible, give oral amoxicillin. If clouding of cornea or pus draining from the eyes, apply tetracycline eye ointment and refer urgently to hospital. So we would identify and administer the urgent pre-referral treatment. We would at this time explain the need of referral to the caretaker of the child. Not only that, we would write a referral note as we did it for a young infant and give the caretaker necessary supplies and instructions while the child is being transferred to the hospital. Another situation is, for example, a child has got another classification which does not have a pink classification. For example, let's take an example. A child has severe pneumonia or very severe disease. Along with that, he also has a classification of fever, malaria unlikely and measles. So in this situation, not only will the child get the treatment listed for severe pneumonia or very severe disease, he would also get the urgent pre-referral treatment that is listed in bold letters in treatment for fever, malaria unlikely. Look at the bold line here. Give 1 dose of paracetamol in clinic for high fever. So if this child who is being referred, he has got high temperature, then one would like to give him a dose of paracetamol before referring him. Similarly, if this child has also got a classification of measles, look at the measles box. It's a green classification, but it has a line written in bold. That is, give first dose of vitamin A. Therefore, if this child is being referred, then we would also give him first dose of vitamin A before referring. Let us recapitulate here. Apart from the urgent referrals, there are other reasons also for which a child may require referral. These are non-urgent referrals, which means we have time to completely administer all the treatment and then refer the child. These non-urgent referrals include referral for severe persistent diarrhea. We can look at the box on severe persistent diarrhea. Here we can treat the dehydration before referral unless the child has another severe classification. So after we have treated dehydration, we will refer the child to hospital. Other reasons which are non-urgent referrals for hospital care are cough more than 30 days. We can look for that in the classification of no pneumonia, cough or cold. If coughing more than 30 days, refer for assessment. Likewise, we would also refer a child who has fever for more than 7 days. Fever for more than 7 days. This would be in the fever malaria unlikely box. If the fever is present every day for more than 7 days, refer for assessment. So these are non-urgent referrals. So one would carry out all the listed treatments and then refer the child. Now let's look at some more examples of identified treatment which requires special care. Let us look at the treatment identified for severe dehydration. In the diarrhea box, treatment for severe dehydration, one would give plan C for severe dehydration if the child has no other severe classification. That is, if the child has only severe dehydration, you would like to give him plan C there. But if along with severe dehydration, he has another severe classification, we would refer the child urgently with mother giving sips of ORS on the way. In addition, if the child is 2 years or older and there is cholera in your area, we would give doxycycline. Now there is another important issue here. You would give plan C at your place only if you have facilities to give plan C. For example, you have a child with severe dehydration but you cannot give intravenous treatment. In such a situation, you would again like to refer the child. So it all depends upon what you can do at your facility. If you can give IV fluids, give. If you cannot and IV fluids are available nearby, then refer the child giving ORS on the way. There might be a situation where you cannot even refer the child nearby, the referral center may be very far. In such a situation, if you can give nasogastric fluids, give ORS through nasogastric tube. If not, at least give the child oral fluids if he is able to take. If neither is possible, that is you cannot give intravenous fluids, neither are you trained in giving nasogastric fluids, then again refer the child urgently as quickly as possible. Now the next situation is that the child does not require urgent referral. That is the identified treatment for the yellow and green boxes. Here one would carry out the instructions as are given in the appropriate boxes. For example, let's look at the box for pneumonia. The identified treatment for pneumonia classification is give cotrimoxazole for 5 days, soothe the throat and relieve the cough with a safe remedy if the child is 6 months or older, advise mother when to return immediately and follow up in 2 days. So these kind of treatment has been identified for every box. So one would like to read that how exactly to carry out this treatment we shall learn in the next section, in the treatment section, but this column just tells us what all treatments are to be carried out. Important issues are that we must give the appropriate drug that the child requires. We have to tell the mother when she must return for follow-up. For example, in the pneumonia box that we just read, the mother has to bring the child back for follow-up in 2 days.
Thank you, Dr. Anju. I think we will continue our discussion with the next session. Now we will have a 15-minute break. We will be again having our next session at 3:30 p.m. Please be with us. We will continue the discussion then.